what is palliative care, and we're going to talk about some 3 foundational concepts that I'm going to compare and contrast as I go through. I'll give you a little bit of background on myself too, is that I am a nurse researcher and very, very embedded in evidence-based practice. I believe that that's very important. But I also have this other side of myself that's philosophical, and so I am also a philosopher, which I don't know if that really fits with an evidence-based practitioner, but I do it anyway. And when I teach my students, I talk a lot about theory and I talk a lot about concepts, because if you don't understand a concept, how do you communicate with one another? Are you clear on what something is versus what it's not? And if you're a researcher, you can't really measure what you think you're measuring if you're not clear on what it is that you're wanting to measure. So we're going to do some interesting things with 3 concepts of palliative care. We're going to look at 2 different philosophies of end-of-life care, one being medical aid in dying and the other one being palliative care, and just talk a little bit about remaining vigilant during this time as we go forward. Okay, so before we get going, Jan Tultz is going to know exactly where I'm going with this. I'd like you to look at this image and tell me what you think this is. What do you see in this picture? And the gentleman from Saskatchewan might have an unfair advantage. So I'm not going to ask him to tell me what he thinks, because he's probably seen this before.
Bad light.
What do you think you see? Yes?
A grassy plain with snow on top.
Grassy plain with snow on top. Okay, anybody else see anything else in that image?
A pathway.
A pathway? Okay. Okay.
Spring is coming.
Yes?
Sheep.
Okay, you got me. Okay? This is the same picture. Okay, let's go back.
Oh, there they are.
There they are. Okay. So this picture was actually taken by a Canadian farmer. Her name is Liesl Kennedy from Saskatchewan, and she went out for a walk one day, and she's a shepherd she raises sheep, and she went out, she was absolutely horrified because she thought her sheep were gone. And she has 550 of them. And so she was, where are my sheep? And on closer glance, she realized they were all there. So, what I want to emphasize is what we think we see and what we want to believe may not always be so. And I think that's exactly what we're talking about when we talk about medical aid in dying and how it's been portrayed by people that really feel strongly about it, and particularly the media. We're going to talk about the media a little bit and how the 3 concepts we're talk about have really been borrowed from palliative care, if you will, and then used in ways that I believe don't reflect what the concepts actually are. So before we get into that, I want to talk a little bit about why we're here, how we ended up here. And it really started before Carter versus Canada. Oh, I've got 2 books that I wanted to bring up and show. There's a wonderful book, I don't know if anybody has read it, called The Way We Die Today. I think that's the name of it, by Seamus O'Mahony. He's an Irish physician. And if you get the chance, there's 2 books, and I'll go and get them out of my briefcase when I get the chance. But he speaks about that society has been moving in this direction for a long time, even before where we are today. And he talks about the rise of individualism and consumerism in our society, and how, as consumers, we want what we want, and we want it now. And this has been shifting. He talks about a decrease in community connections. When we once had people that lived together in communities, people shared meals, They shared relationships, that we're very much in a society where people come home from work, they go in the garage with the garage door, put the door down, and we may or may not even speak with our neighbors. And so that idea of community, we know, is very, very important, and we're at a loss for that in society today. He talks about spiritual dwarfism, that where spirituality was so important, and I'm talking about spirituality in the broad sense, but I think if we talk about religion as a form of spirituality, we can see that as well, that our churches are empty. People may be engaging in spiritual type behavior, but it's become much less important to many folks today in society. He talks about the boom of the funeral industry as another factor. I don't know about you, but we've got funeral homes. We've got beautiful funeral homes that have cost millions of dollars, and they're multiplying like crazy. He talks about healthcare as now, rather as being a shift from really something that physicians, nurses were called to, that it's become more and more service agency. So we're servicing people, right? And when we talk about medical aid in dying, that's how the Ministry of Health actually referred to it when they visited Windsor, and they called this a healthcare service. So it's not about care, it's about service, and that a lot of what we're doing, and death in particular, has become very medicalized. Where once it was embedded within community, people cared for one another. The actual dying process would happen in the home. When people grieved, they grieved together. And it happened over a lengthy period of time. And we're seeing that has absolutely shifted. Those of you that may have had a family member die, you realize how quickly that happens. And people are often have their heads spinning because they're back to work in 2 days and haven't actually been able to grieve. This is probably one of the most significant factors. And that's that as a society, we have a fear of death. It's not something that is comfortable to us. It's not something that we're comfortable talking about. And so it's this fear of death, and we get into to talk about dignity. This fear of death is one of the biggest inhibitors of people feeling that they're going to have a dignified death. So all this is happening before we ended up with our Supreme Court decision. And I'm sure everyone in the room is aware of what happened. Carter versus Canada. And so the court held that the provisions in the criminal code violated the charter. And so basically folks were being deprived of their right to life, to liberty, and to security in a way that's consistent with fundamental justice. And then on the heels of that, took a little bit of a bit of time, we ended up with Bill C-14. Okay? So I just want to clarify what Bill C-14 really means. This comes from my own standard of practice for nurses, and this is how it's defined based upon Bill C-14. So what this means now is that a nurse practitioner, this is Ontario, a nurse practitioner or physician provides assistance by administering a medication to a client at their request that causes their death. Okay, so this is direct administration of a drug. Or an NP or physician prescribes or provides a medication to a client at their request so that they may self-administer the medication and in doing so cause their own death. Okay, so that's how we're defining medical aid in dying in Ontario. So let's contrast that with palliative care. A lot of the work that I'm doing right now with my students, with my research program, with teaching, is in the realm of palliative care. And I think that's important that everyone in this room leaves with a clear understanding of what it is. And so this is the definition from the World Health Organization. It's an approach that improves the quality of life of patients. I would probably change that to individuals if I was a World Health Organization person. So improves the life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Okay, so that's in the broadest sense. But I do want, I've got a whole list of things of how they do that. Okay, and so I feel it's really important that I provide that list, and I don't have them memorized. Okay, so they do this through the following: providing relief from pain and other distressing symptoms, affirming life, and regarding death as a normal process. It intends neither to hasten or postpone death. Palliative care integrates the psychological and spiritual aspects of patient care. It offers a support system to help patients live as actively as possible until death. Offers a support system to help the family cope during the patient's illness and in their own bereavement. Uses a team approach to address the needs of patients and their families, including bereavement counseling. Uses a team approach, and this is where I come in because my interest is very much in collaborative practice and how we can engage various disciplines to work together. So it uses a team approach to address the needs of patients and their families. Including bereavement counseling. Will enhance quality of life and may also positively influence the course of illness, and is easily applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. Yes? Sorry? Where's the list? I can provide you with the list if you'd like it at the end of the talk. Okay, so that is palliative care in a nutshell. And there's people that can speak to that better than I. Jean here in her pioneering work, and I actually have my cousin here as also pioneer right in this neighborhood in palliative care. I think it's important to understand, we also need to understand where palliative care has come from. And so, I mean, it's been done over hundreds and hundreds of years, but it is very much rooted in Christianity. The one thing I want to emphasize, first of all, is that palliative care acknowledges suffering as a human condition. And people listen to that word suffering, and we automatically have a negative connotation. I mean, who wants to suffer? Who in this room would want to suffer? Okay? We have to acknowledge that it doesn't matter who we are. There's no way to avoid it. And it's not necessarily a bad thing. Okay? So if you think back to, some of you probably haven't thought about this, the first time you suffered was when you exited your mother's womb. And you screamed, okay? Not a comfortable thing to be squished through a small orifice, okay? And we can argue that you don't necessarily remember that, but the neurologists are now starting to think about whether that actually is a form of trauma, and some of the things that people go through are actually related to that trauma of being born. So if you want to say you haven't suffered, you absolutely have, right? And even though for women there's some decent drugs out there, I was first in line. I have to admit, it doesn't mean that you might be comfortable physically. But I can tell you, I wasn't necessarily emotionally comfortable. My husband can actually, if he were here, he would absolutely be able to vouch for that. So, as humans, we experience suffering every single day, right? It's part of who we are. It's part of our experiences in life. We have conflicts in relationships that cause us emotional suffering, anxiety, we have stress, and then we even get to bigger existential things like, why am I here? Okay? Ravi Zacharias has written a phenomenal book, another one that I'm going to put out. It's called Why Suffering, and helps us to understand, why it is that we suffer, and that it really is part of the human experience. So, and from a Christian perspective, we also acknowledge the ultimate suffering that was done by Jesus Christ. And the reason suffering started for us was because of the fall of Adam. Before that, we certainly had none. And then the ultimate suffering happened at the cross. So, mostly, we're rooted in the healing ministry of Jesus and the apostles. So when the palliative care movement started, it was modeled under that work. And that work talks about 4 types of work that people do in palliative care. The first is the work is incarnational. Okay, and that means that we don't do palliative care work because we're sympathetic. Okay, it is because we're going to talk about the idea of compassion, which is way bigger than what sympathy is, and not at all the same thing. Okay, the work is evangelical. It means that we're reaching out to others with that compassion, and we're doing it as though we're reaching out to God by reaching out to others. The work is restorative. And the nature of restoration in this context is about bringing people into community. So it's a community of care providers. Whoops. How do I get out of this?
Quick PowerPoint at the bottom.
Okay.
Foundations of Palliative.
No. Doesn't like it.
On the right hand side.
This one?
Yeah, that's it.
There we go. Okay, so the work is restorative, and that means, as I said, we're bringing people into, providing them a sense of community. And that community can be however the person defines their community, family, neighbors, whoever that is. And that community also includes that palliative care team as part of community. And lastly, the work is compassion. And so when we go back to this root in Christianity, it refers to compassion as something that we're motivated to do because we have love and we respect and want to care for other people. Okay? So palliative care, I mean, the benefits, the literature's full. And these are 5 things here. I mean, we could go on a whole talk on the benefits of palliative care and the science behind it. I mean, the evidence is strong. There's been some really, really strong research done on palliative care. We know that when it's delivered well, that it can increase quality of life. We can measure quality of life. It can reduce intrusive medical intervention where it's not warranted. Certainly, it can manage pain and symptoms, okay? And Jean will speak about that, what we have now that can do that. Reductions in spiritual distress. And this is actually really important because when folks have what Cicely Saunders calls total pain, and this is what often will bring people to the point, the brink of, I can't manage anymore. And a lot of that is spiritual pain. So the fact that palliative care can reduce spiritual distress is highly significant. And then this is what all the Ministry of Health is concerned about money. So when we get down to dollars and cents, it can decrease unnecessary readmissions and length of hospital stays, which is, you know, what our funders are most concerned about. Okay, so if you haven't guessed by now, I'm a strong proponent of palliative care. Yet, along comes medical aid in dying, and we have a very, very confusing situation. So, you know, we've got, as I like to call May, the wolf in sheep's clothing. So, we're going to now, you know, move to, there's several concepts I could have chosen to talk about, but we're going to talk about three in this talk, and those are compassion, dignity, and a good death. Because these are the things that, for me personally, have been bothering me as I've been going through my Twitter feed and seeing what's written about in newspapers, etc. So we'll start with compassion. I think I'm going to ask you, how do you define it?
Suffer with.
To suffer with. Okay, so that's a dictionary definition actually of compassion. And co-suffering. Okay, so that comes from the Latin. What you're going to see is you're going to say, okay, she's playing right into the medical aid and dying people. Because as we look at each one of these, you're going to see that some of these things actually could be, you could argue either way. But there's some essential pieces that we're not going to see in medical aid and dying. Okay? So we're going to play with these concepts. I don't know if nursing is the only discipline that does this, but we like to do these very long, rigorous type of reviews that basically torture Ph.D. students. And their committee tells them they need to do this before they can even develop a research proposal, and that's to do a concept analysis, which used to be something Ph.D. students did for their whole dissertation, and now Ph.D. students have to do that in about 2 weeks. So anyway, I don't know if you've ever heard of them in where you're from, but it's something that if you mention concept analysis in any nursing program, people want to just keel over. So we'll start with definitions. So the definition is the feeling of emotion when a person is moved by the suffering or distress of another and by the desire to relieve it. Okay, so that's why it's not sympathy. Okay? Because it moves us to action when we have compassion. Okay? Compassion is, if you look back, the root of many religions, so Judaism, Christianity, Islam, so it's a universal concept that people that belong to a faith group will readily say that compassion is important. It's also not the same thing as empathy. Empathy gets a little bit closer to it. Empathy is more of walking in someone's shoes. That's the way how I like to describe it. But it's still vicarious participation in someone's emotions. You're not trying to truly share that journey. Okay, so that's probably the closest thing in the palliative care. We talk about sharing the journey. Okay? And so when you see synonyms, and these come from the Oxford Dictionary, and the word mercy came up, I went, ooh, it's exactly what the Maid people, right? Yeah. Mercy killing. It's the first thing I thought about. But mercy, if we go back to the roots of palliative care, which is in Christianity, mercy, and back in Jesus' time, was about showing that absolute forgiveness and pardoning, if you will. So here's the stuff that comes from the concept analyses. Now I want you to pay attention to these. So as a concept, these are the people that have done the work. It's a moral virtue that requires acceptance, affirmation, enactment, and evaluation. Okay, I read that and thought, yeah, makes sense. I noted the word evaluation because I'm thinking if the MAID people want to say they're compassionate, right now I'm not seeing any evaluation strategy in any of the things that they're proposing. At least anything that's going to be transparent that we're going to know about. It's not simplistically about taking away another person's pain or suffering, but is about entering into that person's experience so as to share their burden in solidarity with them, and hence enabling them to retain their independence and dignity. This one just shouts out. What are we doing? So how do we practice compassion? Because I think that's really important, particularly when we're talking about medical aid and dying, we're talking about an intervention that is going to become part of practice in healthcare. So conceptually, this is what the practice looks like. Walking alongside another person. It's about presencing, so we can do that by sitting with someone. Simple gestures like sharing laughter, sharing tears. And I love this last one. It's giving and receiving unconditional love. So it's a give and take, it's back and forth, right? I don't see an intervention here. I don't see anything talking about ending someone's life in the compassion literature. It's just not there, okay? Nowhere in the literature where I looked is there anything that suggests that legislation is going to achieve compassion. I mean, the two things are incongruent. They don't go together, okay? This is where we get sticky. We start talking about dignity. And this is where the dying with dignity people have really played on this term. And it's almost warped now. If you mention dignity, I bet you if you walked around downtown Toronto and you asked them what dignity is, the first thing they're going to think of is dying with dignity. Okay? So definitions, again, from the Latin word, dignities, meaning originality and value. The quality of being worthy of honor or respect. And nothing on physicians, but it certainly in the literature is a moral responsibility of nurses. Maybe that's why they've left registered nurses out. I don't know. But here's the concept, and this is where I'm thinking I can get where the dying with dignity people have really latched onto this. Because the concept is made up of 4 what we call attributes or characteristics when we do concept analyses. Respect, autonomy, empowerment, and the last one's communication. So if you are a proponent of MAID, you're going to look at that and say, absolutely. It's about respect. It's about autonomy. It's about empowerment. The last piece, though, is where it gets snagged up a little bit, because this communication really has to do with that team, that interprofessional collaboration that right now we're not seeing. Right now, when we look at practice and how this is going to happen, it's a series of interventions. I don't see any interprofessional collaborative care going on, certainly in the settings that there's hemlockaid.org, okay? I don't see this comprehensive collaborative practice. The concept is also independence in all matters related to disease and the right to participate in all decisions, especially decisions related to the disease process and treatment. So you can see why they've grappled with this. But then I found some interesting literature as I was surfing some of these concept analyses, and there were some specific to end of life. And this is the idea that loss of dignity, as I said, is caused by fear of death. So I'm thinking, okay, if that's easy, how do we get rid of the fear of death? And what do we know about palliative care? That's what they do. Okay, they have the, and do it with expertly providing that psychosocial and emotional support that you're not going to get at an end of life. What Jean likes to call a, well, what were you calling them? Euthanatorium?
Euthanatorium.
Yeah. Okay. This is the other thing that I thought this was beautiful because I'd never found this before. And this is going to be my argument to the College of Nurses of Ontario. Nurses need to possess dignity in order to maintain it. What do you think is going to happen to nurses when they're forced to engage, to participate, even actually be present when this is happening? We're not protecting the dignity of our care providers. Now this speaks to nurses. There's a lot out there about what's going to happen when we're not trusting physicians, nurse practitioners, pharmacists prescribing. So the nurse has to have dignity to be able to provide dignity. And if it's something that's forced upon him or her, I'm not sure how that's going to work. Yes?
So I'm not sure this process you're going through with this definition, concept, and practice of these words. I just have a question about the loss of dignity. So for me, dignity comes no matter what ability or independent idea I have of myself or anything at all that I can do. My dignity is inherent in me.
Exactly.
So I don't think you can lose dignity. So this analysis you're talking about, these words, did they take all walks of life, all religions, all faiths, or is it just a secular analysis?
Well, they're based upon the literature that's available.
So
Yeah.
scientific literature.
Yeah.
Literature is
Yeah.
available. Because I have fault with the first line.
Well, and see, that's one of the preambles that I didn't give. So we've got to remember that all three of these concepts are very, very subjective. So this is what the literature says, and your experience can be the same, it can be different, right? And that is the difficulty with this, the whole debate, in that we are all individuals, we're all different, and in our own worlds, we experience the world in very different ways. Okay? But this is Cicely Saunders, and I love what she says. Notice it's in the present tense. She's not talking about past tense. You are who you were. She's talking about the present. You matter because you are you. Okay? And that's what she's getting into. The wonder of who we are as persons. And we're not just about a symptom, such as pain. So the great thing about dignity, and you have a great point, people can, and that's what the medical aid and dying people are doing, they're arguing that we can take away people's dignity. Okay? We actually can very much work to maintain dignity, and in palliative care, there's lots of ways to do that. So, respect, participation in decision making, privacy. Okay, now this is where your medical aid and dying people are going to get a bit stirred up, because the concept analyses tell us that practice is about keeping people independent from mechanical and survival aids that decrease quality of life. Okay, but once again, let's emphasize the last part. We're talking about moral comfort, and spiritual and cultural needs are very, very important. Once again, something that we're not going to see in these clinics. We're not going to see in a busy hospital institution when a person is wanting this. I know. I see my students in practice, and the nursing staff are not going to have the time when they are invited to do this. And I say the word invited tongue-in-cheek because it's not going to be an invitation. It's going to be you're doing this to actually sit and provide those needs. What we also know about dignity, and this is something that is very, very much rooted in palliative care, is that we can influence it, And so Harvey Max Chochinoff has multiple interventions, dignity therapy, ways of doing dignity therapy that actually can enhance. And this is the kind of work that goes on in palliative care. We can also assess it to know whether someone perceives dignity. He's got numerous measures, but this is his basic, it's called his PDQ. What do I need to know about you as a person to give you the best care possible? Wouldn't you love to have that question asked of you as a patient? Well, it is. Happens in palliative care. That's what the team does. Okay, last concept. This one was interesting. A good death. According to the literature and dictionaries, death in which the rights of the person have been respected and during which the dying person was made as comfortable as possible and was in the company of persons he knew and loved. Okay? Let's build on that. It involves a sense of community before and after the death. Not going to get that in medical aid in dying. It's not part of their process. Actually, it's not even a process. It's a series of interventions. Okay? Calculated. Very calculated. The challenge, I'm going to put this right out here with a good death, is that it actually comes from, in Greek, the translation is euthanasia. And I did not know that, okay, until I prepared this talk. And I had never heard good death used as part of the medical aid in dying rhetoric until just recently. Somebody actually used the term, and this is what made me angry, because I felt like these words are being misused. But if we go to the concept analysis, dignity recognizes suffering. So here's where the lack of congruence comes in. That we say we can have dignity and suffer at the same time. And this is what our people that are advocating for medical aid in dying are saying. That for them it's about getting rid of suffering. Okay? It also includes pain and symptom management, awareness of death, patient's dignity, family presence, family support, and collaboration among patient, family, and healthcare providers. Where have you seen that before? Palliative care. Very, early on slide, defining what it is. There's another one. A good death is a spiritual death, dying with peace, natural death, death during sleep, and having control, comfort, a sense of competence, confidence in caregivers, and respecting values and beliefs.